Hi, I'm Jay Skyler from the University of Miami, and I've got three illustrious colleagues with me this afternoon.
Yeah, Stephen Kahn from the University of Washington in Seattle.
I'm Lee Pro from the University of Colorado Andrews Medical Campus.
Hi, Sanjay Kaul from Cedars-Sinai Medical Center in Los Angeles.
Sanjay, why don't I start with you? And if you had to give me crisply the major messages from the cardiovascular outcome trials in diabetes that have been conducted the last few years, what would be your summary 2 or 3 points?
So in patients with at high cardiovascular risk, we have 3 classes of diabetes drugs that have shown that they have ruled out excess cardiovascular risk. So they are safe from cardiovascular point of view. And 2 of these, amongst these, 2 drugs have also shown clear evidence of reduction in cardiovascular outcomes. And so that's the most exciting part, that trials that were designed to establish cardiovascular safety, some of them have ended up showing that there is risk reduction in cardiovascular outcomes, including cardiovascular death, which till now was the holy grail of diabetes medicine. So that's the most exciting part.
And Steve, you're big on GLP-1 receptor agonists. Why do you think, what's the mechanism by which they're showing cardiovascular benefit? What are your thoughts?
So Jay, that's a great question. I don't think it's really clear what the mechanism may be, and what's interesting is that only 2 out of the 4 agents so far that have really been marketed have been demonstrated clearly to have some benefit. And again, that also remains an unknown. So versus the SGLT2 inhibitors, where maybe the mechanism is a little better understood, I think one can postulate effects in a variety of places, including the heart, and then indirect mechanisms that could relate to weight loss, fat metabolism, the kidneys, wherever you want to go. So I don't think we really have a true answer as to the direct mechanism.
Lee, do we have a better understanding of why the SGLT2s have beneficial effect?
I think it really just depends who you ask, which I think is why it makes it so much fun to think about. Because if you talk to an endocrinologist, they're going to tell you that it's all figured out. It all has to do with this low kind of gray ketosis and the fact that that's a really high octane preferred substrate for myocardial oxygen use. If you talk to a cardiologist, they're going to say, no, absolutely not. It's all about resetting the Starling curve. It's all hemodynamics, right? Okay. And if you talk to a nephrologist, they're going to say, no, no, it's neither of those 2 things. It's all about tubuloglomerular feedback being reset by the drug class. And so I think it's so much fun because depending on who you talk to, you're going to hear something different and you're going to learn a little bit something different. And it's probably, honestly, a little bit of all of those things.
So I think it's cardio-renal metabolic.
Oh, good answer.
Probably right.
Good. I like that.
Make everybody happy.
Exactly.
Which means that we simply don't know.
Correct.
Now, are there extra benefits that we get from having this? To, you know, there's been a postulate that perhaps you want to treat heart failure with SGLT2s?
Absolutely. I mean, it's amazing, I think, what we've learned from the class, and now the class is under investigation in people for, you know, preventing chronic kidney disease without diabetes and people who have heart failure without diabetes. And so I think the utility of the drugs is going to be a lot larger spread and have indications beyond diabetes because of its potential use. And so I think, yeah, absolutely.
So Stephen, the DPP-4s were studied, 3 of them. And as Sanjay already said, they were safe.
Correct.
But they didn't improve heart disease. And in fact, there may have been a signal for increased heart failure. Controversial, but it certainly ended up in the label for 2 of them.
All of them.
All of them.
All of them.
Which raises another whole spectrum of why we doing these studies. In a sense, if we get results and then the FDA still does whatever the hell they want to do with them. But yes, you're right. Jay, I think knowing where your question's really going, I think the issue is...
You do?
I think so. I think so. Yeah, I would say to many it was a surprise, in fact, that they turned out to be neutral from a cardiovascular point of view because they're safe for sure. But I think using the meta-analysis approach, everybody was thinking we're going to see 40% reductions in risk of cardiac events in these individuals. So I think we've learned a lot of things from these studies, these big clinical trials, aside from the primary question. And in this instance, I think it's taught me also, and I think we need to all think a little seriously when we're taking these large pooled analyses that come from different populations and put together, that they indicate what may happen, they don't indicate what's really necessarily going to happen. So yes, they're safe and they work well.
Yeah.
There are two key lessons to be learned from the DPP-4 experience. The pleiotropic effects are just exactly that, a black box. And we really need to have reliable evidence generated from randomized controlled trials. The second key lesson is that meta-analysis do not yield reliable, credible evidence for regulatory and clinical decision making. So there are many examples of similar disconnects where the meta-analytic estimates are favorable, and when we do the randomized controlled trials, the most famous example is rosiglitazone, upon which the entire 2008 guidance was based on. So the word of caution in terms of the preclinical and the meta-analytic.
So, but given the positive results with SGLT2s and GLP-1 RAs, why bother to use DPP-4s at all?
Yeah, well, I classify physicians into two phenotypes. Physicians that prescribe therapies that are safe, regardless of whether they're effective. Okay, errors of commission trump errors of omission. That's their philosophy, first do no harm. And then there are physicians like me who only prescribe therapies that are effective with acceptable safety trade-offs. So the reason why DPP-4 inhibitors are being prescribed so commonly is because they have a pristine adverse event profile. And so physicians don't like to be called by, by patients, hey, I was doing perfectly all right and you prescribed the therapy and now I'm only experiencing the adverse events. I am not experiencing the benefits. So that's probably the only reason I think that the DPP-4 inhibitors is a $10 billion market.
But I think it's an important point, Sanjay. If you take the elderly and you're going to give them SGLT2 inhibitors and change blood pressure and intravascular volume, and then these people struggle with hypotension, then you've got people you don't want to give injections to, or you've got elderly, you've got weight loss. So there's a place where the DPP-4s might be incredibly useful. I want to add something else, though, to all of this that we mustn't forget, and I think is critical in all of this discussion, Jay, is that whatever these agents are that have looked beneficial or suggest they're beneficial, so, groups who've done a lot of these GLP-1 studies have then pooled their data to try and suggest it's a class effect, yet the clinical trials only show up for 2 of them at the moment. We must remember these people, like you said, are individuals with known cardiovascular disease. When you look at those studies with a few people, 20, 30%, who had never had a previous cardiovascular event, there is no appreciable benefit of these drugs in those people. So we really are looking at a group of individuals who've had a prior event in whom we're seeing the benefit of the SGLT2 inhibitors and GLP-1 receptor agonists.
But I'm going to challenge that for a bit, because the studies are really very short. And people who are at lower risk and haven't yet had an event, it may take longer for the curves to separate, and you have to do a longer study to prove it in them, and it would be my guess.
I don't disagree with you, but we've also just talked about the fallacy of meta-analyses. So until you've got that randomized clinical trial, I think we need the data. So I think it's incumbent on the manufacturers of these drugs to prove to us that they actually do have a benefit in individuals who might be very high risk, don't get me wrong, but have not yet had a stroke or an MI or something like that.
So while we are at analyzing the strength of the evidence, we have criticized meta-analysis. I think we have to also be aware of the fundamental flaws of long-term follow-up of randomized controlled trials. When you follow them for 10 or 20 years beyond the period of randomization, they are no longer a randomized control group, and they're vulnerable to residual confounding. So to make claims of macro and microvascular benefits on long-term follow-up is similarly flawed.
Fair enough, but if you're going to go that way, the size of these trials has been huge. And then there's this 342 patients who are, in which it's claimed that metformin reduced heart disease. Do you believe that?
No.
No.
It should not be. If metformin were submitted to the FDA with the kind of portfolio of evidence that it currently has, it would not pass the regulatory muster. And yet, everywhere in all the guideline recommendations, that's number one. Why? Because we are very facile with its use. It has a pretty clean adverse event profile, and it's inexpensive.
Yeah, but isn't inexpensive driving that more than anything else?
Yeah,
Because
I agree.
most people underdose it. They don't get to, you know, the average dose in the United States is somewhere between 1,000 and 1,200 milligrams a day. And the dose response curves show you really don't get the effects until you're at 2,000 to 2,500 milligrams a day.
I think it depends on what you're looking for from a point of view of an effect, Jay. I think two comments to what you just said. The first one would be that you don't get as good a glucose lowering, I agree with you, with less than maximal doses. But I think we've also seen in some of the clinical trials that you can actually get people to those doses, the maximum doses, which would be in this country considered 1,700 milligrams a day in divided doses, if you actually take the time to work with them. And I think part of the problem is that the physician doesn't have the time. So that's where the problem comes.
Sure.
But we've certainly seen in these studies where we're giving people, for example, the diabetes prevention program, metformin as a medication to prevent diabetes. So it's not even like they've really got diabetes yet. They're pretty compliant, and the vast majority of them were on 1,700 milligrams. So you've just got to work with them.
Yeah, agreed if you work with them, but that's not the way it's usually done.
I absolutely agree.
Okay. So how many would argue that instead of starting with metformin, we should start with one of the others, an SGLT2 or a GLP-1?
I would favor that.
I would favor that too.
So I think we'll find out soon, right? The American Diabetes Association, the European Association for the Study of Diabetes are coming with new guidelines. It'll be interesting to see what these individuals who've scoured the literature, we hope, weighed the evidence, and then thought about it, think about it, so what they come up with. I think the other thing, which is towards what Sanjay said about price, which is important, is I think we've got to think about what we want to use and where. And here my message is not to say that you shouldn't use these other drugs as first line, but if you're in a situation where somebody is struggling with healthcare, I think we've got it's incumbent upon us to give them something. And here I would argue metformin is clearly first line.
No, absolutely. Should we be using sulfonylureas at all anymore, Lee?
You know, I get asked that question all the time, and I do. I will admit it, even in this conversation we're having right now, in patients in whom we can't get other things. It becomes exactly what Stephen was just saying. It's an access issue. So to say that I would rather leave my patient untreated rather than treat them with sulfonylurea, I wouldn't do it. And it's still, you know, we still have to remember that we may not be preventing macrovascular disease, but we're still preventing microvascular disease by lowering glucose.
So Jay, you know, when you think about sulfonylureas again, it'll be interesting to maybe get predictions from Sanjay and Lee, and maybe even you, right? If we think about sulfonylureas, as we talk about metformin in the UK PDS, the whole sulfonylurea thing in terms of cardiovascular disease is built on the UGDP. Then that was thought to be flawed, right? So, okay, you can still use sulfonylureas. Then one company will argue mine's safer than yours or whatever. I think we're going to learn something at least about this next year when the Carolina study reports where we're looking at linagliptin versus sulfonylurea. And that study, I think, once and for all will give us some true feel whether these drugs are high risk for cardiovascular disease or not. And then I think if they are, then one's really going to have to struggle with what to do with it.
But Stephen, that study doesn't have a placebo group in it.
But that's okay because we know that linagliptin is not going to be cardiotoxic unless it's a heart failure outcome. Right. So we know it's like a placebo. Right. It's safe.
It's a safe glucose-lowering agent.
We recognize that.
Yeah,
well, also there's two trials, right? Carolina and Carmelina.
Yes.
And one of them is
but they're separate trials. And
correct.
Every time you try to merge data from two trials and interpret it like it's one, you get in trouble.
I mean, the reason it's important to understand why the FDA required the sponsor to do a placebo-controlled trial, because the active control in the Carolina trial was glimepiride, and it's never been proven to be safe. So if you show that your new drug is non-inferior to a drug with no characterized cardiovascular safety, then your new drug is just as bad as your control. Right. So there's no way you can establish safety of the new drug. The only way you can do that is the placebo control.
Which is where Carmelina will sit, will at least give us some feeling in a population of high risk with renals, on the renal side, right? But will give us some feel of whether linagliptin is or is not safe against what you're calling placebo, which would be all the other therapies. And then the Carolina will come afterwards and will answer this question. And you know, I think it's important from the point of view, we're very lucky in this country we can have these choices, and a lot of people can utilize the choices because of the nature of their insurance. But in other parts of the world, you don't have those choices, so being informed about this will be important in terms of healthcare delivery in other parts of the world where diabetes is also a problem.
But I think one of the things we need to do in this country is change our healthcare system so we don't face the problem Lee is facing of patients not being able to afford their drugs. We ought to be able to provide whatever is the best drug, in our view, and not be limited by the fact that we have a really backwards healthcare system.
Instead of providing guns to the teacher for ensuring safety? I think that's a great idea.
Oh, yeah.
And on that note, I think we'll conclude, and I want to thank folks for watching.